So this is the first case, a 16-year-old boy with a BMI of 28, presented with edema feet and abdominal distension, born of a non-consanguineous marriage. On examination had icterus, edema feet, moderate ascites, had mild tremors, his faces were expressionless, and he was walking rather slowly. His gait was slow. On investigations, albumin was low with a globulin of 4.5, bilirubin 3 mainly direct, INR 2.2, enzymes were moderately raised, alkaline phosphatase of 780 and GGT of 220. He had pancytopenia, though platelets were not very low, of 1 lakh, lipid profile, blood sugars were normal. Sonography showed cirrhosis with portal hypertension, and ascitic tab revealed a high SAG ascites, which is suggestive of portal hypertension, and small esophageal varices on endoscopy. So the question is, any comments on the diagnosis to the panel? What do you think is the diagnosis?
Well, this is 16-year-old with liver cirrhosis and chronic liver diseases, and for that particular age group, the 4 things that I commonly would think of is Wilson's, autoimmune hepatitis B, and maybe hepatitis C. I mean, just based on the liver disease. There were some suspicious changes of neurological in terms of his facies, etc. But if you just look at the liver problem, I mean, these are the 4 that I would put at the top of my list for investigations.
Okay. So I'll proceed. We did a etiology workup. He was hepatitis B, C negative. Autoimmune, ANA was 1 in 40, just positive. Other autoimmune markers were negative. Ceruloplasmin was slightly low at 15, normal being 20 to 60. We did a 24-hour urine copper estimation, and that was 75. And he was given a challenge, after which the copper came up to 340. There were no KF rings. And we went ahead with a liver biopsy which showed macrovesicular fat. There was some cholestasis, mild interphase hepatitis, and it was mainly lymphocytic, and a copper strain was positive. We even estimated his liver copper, and that was about 210 per gram dry weight of the liver. Comments, Prem?
So I think a lot of the findings here are consistent with the suggestion that this is Wilson's disease. Low ceruloplasmin, after depenicillamine, the copper does go up. Macrovesicular fat, I think, would go along with that. But right at the very beginning, the fact that this patient had high GGT made me feel a bit uncomfortable about putting Wilson's at the top of my differential, that there was something else going on. And so when you look at the liver copper in this patient, it's about 210. It's kind of modestly raised. And the question is whether this is a heterozygote carrier of Wilson's disease who has developed some other condition on top of that. What I find very useful is to look at electron microscopy of the mitochondria in these patients. The EM appearance of the mitochondria is absolutely pathognomonic, and when you fall into this kind of a gray area, for me, the EM of the mitochondria, looking at the inner crystal kind of deformity of the mitochondria, is often the final arbiter of whether you're looking at pure Wilson's or someone who is a heterozygote carrier of Wilson who has developed another comorbidity in the liver.
So you are not very convinced that this is a pure Wilson's?
I think there's some other process going on. This could be pure Wilson's, but in order for me to be convinced that this is, that this patient has Wilson's disease, I really want the electron microscopy and report on the mitochondria. If possible, I would like to look at ATP7B gene mutations.
Will that help? We don't have any blood from a sibling or anything, so.
No, so the index patient can have gene sequencing, so we don't necessarily need the other siblings or parents. So in the days when we couldn't do the entire gene sequencing, we relied on microsatellite markers and haplotype analysis. Now, you can essentially sequence all of the 21 coding regions of ATP7B. And so one person is enough to do the mutation analysis. The challenge with genetic testing is that if you have one mutation, then it makes it a little, your case for Wilson's disease starts to get stronger.
Yeah.
But very often, you only have that one mutation.
Yes.
And the other allele is not found. And if you look at the large series of Wilson's patients in Austria and elsewhere, where they've done ATP7B gene sequencing, Aabha, up to 30% of patients who have the phenocopy of Wilson's disease, they do not have ATP7B mutation. And so the key question is, are we dealing with genetic heterogeneity? Are we going to have a situation like with hemochromatosis, where there are all these other genes involved in the iron transport pathway? When they are mutated, you have the same phenotype. But in relation to this, coming back to this patient, I think ATP7B gene sequencing might help you a little bit, but based on this data, I think that he might be a carrier of Wilson's, or maybe he has a mild form of Wilson's. You know, I'm not too impressed by the liver copper. I would be interested to know what Dr. Ashish thinks. You know, this is a kind of liver copper I would put down as heterozygote carrier. I think there is a second process going on here.
Okay. Ashish, any more comments?
Coming to the mutations, we have one advantage that at least whatever little we know of mutations, most of our mutations are homozygous mutations because of the consanguinity that is there. So we have very few double heterozygotes.
Can you use the mic closer?
Yeah, when we don't have so much of double heterozygotes as compared to the West. So if you generally pick up one, it's almost there on the other side. So it's slightly more easier. If you take the classical definition for making the diagnosis of Wilson's disease, this child does not have it. I mean, if you say that I would define Wilson's with a low ceruloplasmin, high urinary copper, and a KF ring, or any two of those three with a hepatic copper more than 250, it's not there in this particular child. However, in our setting, we know that our liver coppers sometimes leave a lot to be desired, so as well as a urinary copper. So with this, I would still think there is a strong possibility that this is a Wilson's, though I would not say that we have the 100% diagnostic way to confirm and stop our diagnostic workup for that. This child also had a very high globulin. I remember you said that in the initial part of it.
It was 4.5. Yeah. Petrus, any comments on the neurology of this patient, neurological symptoms?
Well, you just said that he had a masked face and slow gait.
And mild tremors.
Right. I mean, I guess we need an examination there. But then the other question is, what did the MRI show?
Okay. So there we go. We thought let's do an MRI, whether that's going to help us. Yeah. Yes, very much. There can be so much copper due to cholestatic liver disease. In fact, we have seen much higher coppers also due to cholestatic liver disease. And since you are there, Amita is a pathologist at KEM. I want to ask, how would you advise collecting the biopsy for copper? Do you know? We do it. I mean, it's done in Bombay. It's done. Okay. Can you come to the mic, Amita? Yeah. Prem, in the meantime, do you want to comment on how should the biopsy be collected for copper? Because that's an important issue. And the way our lab here at Kasturba Hospital asks for it is in a dry bottle. The moment it is put in formalin, they say they cannot estimate the copper. So that's one thing which we want, because once if the biopsy is done and if Wilson's is a differential at all, one should keep it a separate piece in a dry bottle. That's what they insist.
And Aabha, you probably remember that's what we did when we were with Sheila Sherlock and others at the Royal Free.
Yes.
But I can tell you all of the big laboratories in the United States, Mayo, etc., they are perfectly happy to get formalin fixed liver tissue and even from paraffin blocks and get enough out to do copper measurement. So I think that methodology is now available, and I think it's less cumbersome because you can just imagine resident trying to divide up little bits, and you
Yeah,
try
we-
and put it, and you're going to lose it, and how much of it is going to be lost in the
Sure.
in just transferring from one container to another.
Yeah.
That's why I really do prefer the formalin fixed specimen. For us,
Well,
it works.
Yeah.
I've never had any problems.
We are not yet there, but I hope soon we are able to do it that way. Yeah, Amita, you wanted to complete your comments.
Cholestasis that is noted in the liver biopsy is not very much in favor of diagnosis of Wilson's.
Okay, point well taken. Okay, so we went ahead and got an MRI done, and not an expert on brain MRIs. Maybe
Yeah, see,
Petrus can comment on that.
This is what you've given us is a T1 weighted image, and you've mentioned that there is nothing on the T2. And all this is showing is hyperintensity in the globus pallidus, which is very, very consistent with manganese deposition. Manganese deposition can be seen in a wide variety of conditions and very, very common in hepatic diseases. So I mean, when there is liver failure of any cause, manganese deposition can be seen. It's fairly common.
Yeah, and we often see Parkinsonian features in patients who are in kind of a chronic encephalopathy, or whenever they keep going into encephalopathy, which can resemble Parkinson's, and in turn they actually resemble Wilson's. So just a point that you could have neurological features which are not really Wilsonian neurological features.
Can I just add a point?
Yes.
That the manganese, in fact, the manganese miners very, very commonly get Parkinsonism just by manganese deposition in the absence of liver disease. So manganese itself can cause Parkinsonism. So some of your features which you're describing may not, I mean, you don't have to think of Wilson's just because there's liver involved.
Yeah, absolutely. That's what we wanted to highlight. And then just to show you what yeah, Prem.
So I think that there is a general point that is worth for these trainees to hear about as well, is that inborn errors of metabolism, storage diseases, there is a kind of a theme that they do cause Parkinsonism. We're going to be hearing about Gaucher's disease, and people have now shown that many lysosomal storage diseases are associated with early onset Parkinson's disease. And in fact, if you look at genetic risk factors for idiopathic Parkinson's disease, Gaucher mutations are the most powerful genetic risk factors for Parkinson's disease. And so I think that Parkinsonism is an important clinical manifestation of storage disease, whether it be with copper or with metabolic, other type of metabolic storage disease.
Yeah, that's a very profound thought, and I think of a metabolic disorder if you see a young patient with Parkinson's. Would you say that?
No, well, I think the thing is young patient with Parkinsonism and liver involvement. I mean, there's a whole lot of other genes which cause Parkinsonism in a young child, and they're autosomal recessive genes which cause pure Parkinson's disease kind of phenotype. This is firstly Parkinsonism we're talking about, not Parkinson's disease. And I think what he's saying is metabolic liver disease, I mean a liver disease with Parkinsonism, then yes, you're looking at probably this group of patients.
Sure. Okay, just to now show you pictures of what it would be like in Wilson's disease. So basically in liver failure, you have T1 hyperintensities, and in Wilson's disease, you have T2 hyperintensities, primarily in the basal ganglia, but can be in other parts of the brain as well. And this is what the MRI is depicting. So we moved on. So finally, this patient was investigated. We thought of a cholestatic problem primarily, which was causing some confusion about the diagnosis, high copper and all. And it was concluded after doing a cholangiogram, an MRCP, that this patient actually had PSC and probably some autoimmune features on biopsy, like interface hepatitis with some lymphocytic infiltrate. And this was an overlap syndrome, not really Wilson's disease. So just to highlight the point of cholestasis can cause confusion in the diagnosis.
Can I ask you, this patient didn't have established cirrhosis, or
this patient had
cirrhosis and
cirrhosis,
portal
yes,
hypertension.
had established cirrhosis and portal hypertension.
And in terms of synthetic function, was serum albumin normal?
It was 2.6.
It was low.
Yeah.
Okay, so the low cellular plasmin is
Yes.
probably
Yes. Yeah.
reflective of that.
Yes.
Because in cholestasis, actually you would see high cellular plasmin.
Yeah.
So that's why I was thinking maybe there was the low ceruloplasmin was really significant, but now it turns out this is just impaired synthetic function.
Yeah. So,
Can I just?
yeah.
I mean, at least most pathologists for the younger sclerosing cholangitis that we get, our pathologist is reasonably certain to tell us, okay, in this child, please look for a biliary tract disease rather than looking at a hepatocellular disease to look at the diagnosis. But when you did the liver biopsy and what you described, there was nothing to suggest that this child actually, or this adult.
They did
or
suggest a biliary disease. I
They
didn't
did,
say
okay.
that there because I
Okay,
didn't
they
want
did
to
suggest look.
let the cat out of the bag. Now, just coming to the points which were alluded to in the discussion, can Ashish tell us, and of course Prem could add on, what are the problems with each of these? We know that no single test or any of these in isolation can diagnose Wilson disease. So what are, if in a minute or so, tell us what are the problems with KF rings, and each of these tests you have false positives, false negatives, and just for the PGs to know.
Okay, for the KF rings, well, if the KF ring is there, it is strongly suggestive. Most neurological patients will have a KF ring. If you have a hepatic, at least in our series, almost 64% of the hepatic Wilson's disease have a KF ring. We do get a KF ring earlier than what is described in the West, but obviously an absence of a KF ring does not mean anything much. And you can get a KF ring in chronic cholestatic disorders also, occasionally. A ceruloplasmin, really, it's variable, but most of the times it is less than 20. It has been reported up to 20 to 30% of the times you may have ceruloplasmin which is slightly in the borderline normal range. It is very unlikely to have a very high ceruloplasmin in a child with a documented Wilson's disease, and any ceruloplasmin less than 5 should be really taken as extremely suggestive of Wilson's disease.
So if it's very low, it's very suggestive,
Yes,
but you
if
may get
it's
a falsely high ceruloplasmin.
Yes.
Okay.
Yeah, and wherever there is activity or something, you can get a ceruloplasmin that is raised a little higher, and on treatment, the ceruloplasmin actually you can see it drop down as time goes on. Serum copper, I generally don't do as a diagnostic method. It's more commonly for prognosis or in terms of managing the follow-up. But we have to remember that serum copper usually reflects the ceruloplasmin. So most of the times, even though this is a disease of copper metabolism and copper storage, serum copper can be low, but it can be normal or it can be high also. So it really, serum copper doesn't help us much by itself, except for its calculation of a serum-free copper. That's where its role is. 24-hour urinary copper is high mostly in active liver disease. It is not necessarily so high in an asymptomatic sibling. A lot of people who measure it accurately depend a lot on it for its sensitivity and specificity, but we have extremely difficult problems in India because the methods of estimation are quite crude. Initially, I think 100 was the cutoff point for making a diagnosis of Wilson's, but now I think they're talking about 40. Anything urinary copper more than 40, you should suspect that that child could have Wilson's disease. The post-penicillamine challenge is a challenge primarily for children, where you give 500 milligrams of penicillamine in the morning before you start collecting the urine sample, and give it again at night. And while the child is on the 2 doses, you start collecting the urinary copper. And if it's primarily used, again, it's going to be more sensitive when the child is having an active liver disease. Unfortunately, it doesn't help us so much when the child is an asymptomatic sibling or doesn't have an active liver disease. Usually the ceruloplasmin goes up to more than 1500 is what is the classically described literature where you use it, and it goes up more than 1500 after a challenge. Some take it as 7 times more, some take it as 10 times more, but various people have their own ways of going up.
But validated only in children.
Validated only in children, and it has also been shown that acute viral hepatitis, you could also have ceruloplasmins your urinary copper is as high as in Wilson's disease. So they do have some sort of false positives. Liver copper stain is, the stains are variable. If you do pick a lot of copper stains, they mean a lot, but if you don't pick it up, it doesn't rule out Wilson's disease. It depends on the stage of the disease. If there is a lot of cirrhosis, you may sometimes not necessarily get at the copper, and it depends from where you take the biopsy piece also. You can really get 2 or 3 nodules, one having a lot of copper and one having no copper. So it depends from when your piece has come up. Quantification of all the tests is still as much of a gold standard as you can expect, though there are false positives and negatives with that also. But I would suggest that if there is a doubt, that is the thing that you need to do to sort of sort out your problems. And someone can add to that. I'm not sure I'm going to talk about my brain.
Just a question, Prem. In neurological Wilson's, sometimes we get a request, can you do a liver biopsy to tell us this is Wilson's? They're not sure clinically whether this is Wilson's or not. Do you think in neurological, predominantly neurological Wilson's, liver tests are normal? There's nothing to suggest liver disease.
You know,
Will liver copper help?
that is a very, very interesting question, Aabha. Because if you think about the natural history of Wilson's disease, okay, the first step that happens is development of silent cirrhosis. And I learned that lesson over the last few years when we've had young children presenting out of the blue with fulminant Wilsonian liver failure. Every one of those child had established cirrhosis and no prior signs of liver disease, normal spleen, platelet count normal, but on on the explant, established cirrhosis. The natural history then starts to divert from that point. Either it goes to decompensated liver disease, or the cirrhosis remains very silent, and patient goes on to start to have neurologic disease. And it is because of that that I think that, yes, a referral like that, I would do a liver biopsy in a heartbeat for several reasons. One, to confirm with the copper estimation that this is Wilson's, but also once you know that the patient's got cirrhosis, it changes how you monitor and manage the patient.
Any comments, Petrus?
No, I think I'll just add to the MRI brain. The MRI brain in a neurological Wilson's would most of the times be abnormal. Obviously a normal MRI doesn't help you, but in many people who have no neurological manifestation, your MRI will be normal. So it doesn't help you when it's a question of hepatic presentation, where it's probably not going to help you with the diagnosis.
Okay, so having now covered how to diagnose Wilson's and the problems with diagnosing Wilson's, we move on to the second case. Can I have the lights off? This is an 8-year-old boy born of a third-degree consanguineous marriage. We discussed third degree last time. Is Rakesh there? I don't know whether he's there. Yeah, he's there. So please don't ask me questions on what was third degree. But this was a third-degree consanguineous marriage with history of distension of abdomen, edema, feet, melena. So there was end-stage liver disease, cirrhosis. He gave history of a sibling dying of liver failure at the age of 7 years, but no diagnosis, unfortunately, was reached at that time. And then this guy is investigated, found to have low ceruloplasmin, and he has a pancytopenia with a platelet count of 75,000. He had obvious KF rings. On slit lamp examination, KF rings are often falsely positive in patients who are deeply jaundiced, and if they are there in a patient who's not jaundiced, it's helpful, but you really need an experienced ophthalmologist to do a slit lamp in a patient who is jaundiced to say that these are indeed KF rings and not bile pigment rings. So we went on to do an ultrasound which showed cirrhosis and significant portal hypertension. There were large varices which were banded. He was started on supportive therapy. Now, what drug would you give this child? Prem.
I was talking to Dr. Ashish about this only yesterday. D-penicillamine's been around for more than half a century. The hardest thing about the use of D-penicillamine is after patients been on treatment for 30, 40 years, and I looked after a few at Royal Free with you, is development of this dermopathy and accelerated aging. It is worse than having Wilson's disease. It's the most heartbreaking thing to see, and you kind of feel an overwhelming sense of having failed in care of your patient. So I think D-penicillamine is not a good drug to take for many, many years. Cyprin is supposed to have less of those side effects, but I shared with Dr. Ashish a couple of cases of young children who on Cyprin didn't have a good copriuresis. And they were continuing to chug along with elevated liver enzymes. And in fact, they even started to have some very subtle neurologics, behavioral issues, very uncharacteristic, but no KF rings, but very high non-ceruloplasmin bound copper as well. And we did a D-penicillamine challenge test, and the urine copper went sky high. And so we changed the treatment. with the rationale that we would treat the patient with depenicillamine for a few years, and then the goal would be either to go to zinc maintenance therapy or zinc and cyprin combination therapy.
Ashish, we don't have cyprin or triantine easily available. Would we still stick to penicillamine as our first drug of choice? What would you do in this patient?
I'm just concerned a little bit about a low platelet count to start with. I think 47,000. So I would be
75,000.
Okay, then
Okay, what if it was 47?
I would be a little concerned. I mean, it's not that I wouldn't start. I would start penicillamine and zinc. Both that's what our policy is, to start both the things at this particular time.
Do you think the two interfere? And
I don't think they interfere if they're given apart.
is it possible to practically give them apart?
Yes, you can.
3 times a day,
Yes.
empty stomach.
Yes, you don't need to
Very
give both 3 times a day.
Yeah.
I give penicillamine 3
Twice
times
a
a day
day.
because initially that's my most important drug, and I give zinc twice a day, hoping that they both act by different mechanisms and the both effect will be symbiotic and hopefully a bit better for the child. I don't think anyone has shown that necessarily that to be true, but I do that. But I make it very, very clear that they keep that gap. If I realize under any circumstances that they are not keeping the gap, then I'll prefer to get off zinc completely and let them concentrate on taking the penicillin itself, because sometimes you would do worse by putting the two
Yeah, which is what we have experienced, that the compliance with the two together separately 3 times is difficult, and they sometimes actually worsen on a combination. So we rather stick to penicillamine alone.
That usually would occur if you would insist that both penicillamine and zinc have to be taken on an empty stomach also.
Yeah.
Because then it's difficult for them to manage.
Yes.
But if you want to put, what we do is we tell them to take it on an empty stomach. We realize there is a problem. I make sure the penicillamine is given on an empty stomach. I double the dose of zinc and make it give it along with food, because we know 50% of the zinc is lost with food.
Okay, that's
So
a
I'm
good
assuming that
practical
25 milligrams would, because that's the dose for the child. So I say, okay, give it with food. At least compliance is better, and they get the time 4 or 5 hours gap between zinc and penicillamine. That's
Okay.
how I approach.
How strict are you with diet?
In the
Both.
Well, initial 1 year, I'm quite strict with the diet. Especially, it again depends on the child. If the child is looking sick to me, the child is just on this borderline of compensation, a little bit of ascites, I would try to insist that they be very, very strict for the first year at least. If the child is just marginally caught very early, I may be a little relaxed in it. But I generally prefer first year to be strict with the diet.
Okay. Any comments, Prem?
No.
Okay. So basically, we have answered this question. So low platelets by themselves should not be a contraindication to starting depenicillamine unless they're terribly low. And we often actually see them improving on treatment because the hypersplenism is becoming better. So that is one point I wanted to raise. Now, so what happened to this child? It's not moving forward, huh? Now, have the lights off? The liver function improved. His platelet counts improved. He went off diuretics. There was no ascites, no edema. But he came back after 15 days with fever. And he had 15 days of taking a drug. This was over a period of 3 months that he improved. And then he said that he had some fever and cough, was given drugs by a local practitioner, and then he came with this. He had swollen lips, ulcers all over the mouth, over the lips, eyes were red, the ears were red and with blisters, and he was diagnosed to have Stevens-Johnson syndrome. Now the big question we had in our mind was, is it the penicillamine which has done that, or is it some drug which he got for his fever which has done that? What would you do next?
Since I don't know what it is due to, I would say, okay, it's quite likely to be because of penicillamine.
It's come 3 months after starting penicillamine.
It's 3 months after
starting penicillamine.
Okay.
Is that possible?
Most of the hypersensitivity reactions are usually very, very early reactions. They come in the first few days after starting, and if he's been on full dose for 3 months and generally has got away with it, I would think that is extremely unlikely.
Prem, any other ideas?
No, I would be. He's had such a good response to depenicillamine. I think he's got Stevens-Johnson syndrome. I guess one of the possibilities you considered was to put him on steroids, which is what you would have done even if this was depenicillamine related hypersensitivity.
Yeah. So actually, when we discussed it with our dermatologist, they said this is Stevens-Johnson's and it is known to come sometime later after the drug has, in spite of the drug being tolerated in the beginning. So in any case, we treated him with steroids. He recovered. We put him on zinc in the interim. We didn't have triantine available. But what happened was we waited for a couple of months. We were a little too scared to restart penicillamine because he actually took a couple of months to completely recover from this. But he redeveloped ascites, and he even came back with an episode of SBP. What next? What would you do now? So the zinc is not working, and as we know, probably zinc doesn't work as fast as we would expect penicillamine to work. So what would you do?
I would again see if it's possible to get triantine. If it is not, I would still think that that first problem may not have been because of penicillamine, and restarted him on penicillamine and hope for the best.
Okay, so we have, sorry.
So here the die is cast. Bacterial peritonitis, 2 episodes of hepatic decompensation. It's declared itself. You need to transplant this patient. Whatever you do in terms of drug therapy, I think you're going to have very marginal impact, in my opinion, in terms of really improving the prognosis here.
Well, I did not put transplant as an option. We just prayed and started him on D-penicillamine again. We didn't have triantine available. And now he's 3 months post D-penicillamine. He's back to his better liver functions. Platelets have improved. There's no ascites. And we still keep praying that he doesn't get it back. Yeah.
But let me be frank. Can you go to the previous slide? Okay, the one after this. The children who came in this situation with developing an ascites and a spontaneous back, and we get many of them, and unfortunately most of them cannot get a liver transplant, so we end up treating them, and a very, very large portion of them do well on medication, even from this stage onwards.
Yes.
We have seen many of them who would come out completely, okay, maybe in the long term we would see, but they would come out definitely of this and would remain well maintained for a long time. So I'm not too sure whether in the West you're transplanting a little earlier or not. That's something that we can debate, but I would not necessarily that this is really something that, and this is just because of the fact that we don't have transplant that we are seeing them even come out of this stage.
Yeah, I agree with Ashish that we have patients with fairly decompensated liver disease, ascites, even SBPs, high INRs of 3, 4, and they do turn around. Yes, the chronic ones. I'm not talking of those who present acutely with encephalopathy, but the chronic ones do turn around. Yeah, so we move on to the next patient. This is a 38-year-old man presented with tremors, drooling of saliva, rigidity and slurring of speech. He works as a writer in the High Court where he has to take down all that is being discussed in the proceedings. So main work is writing, and his biggest problem was that his handwriting had completely changed and become illegible. He also had, which did not seem to be his main complaint, but he said, no, I have a little bit of distension, there is some swelling on the feet, and he gave history of a variceal bleed for which he underwent band ligation. On investigation, he was a child C cirrhotic with portal hypertension. He had a fairly high MELD, and tests confirmed that he had Wilson's, he had K-Frings, and he had a low ceruloplasmin. So we started him on D-penicillamine. Not a high dose, about 1 gram a day, and within 15 days, his neurological symptoms significantly worsened. Petrus, comments?
Yeah, I mean that's the real problem with the penicillamine, especially in the neurological Wilson's. You do expect that there's going to be worsening once you give the penicillamine because of release of copper. So in fact, what we do now is to give very, very low doses, probably just 250 milligram a day for a week, wait and watch, then maybe if he's doing okay, then increase it after another week or 15 days. It's slower, more painful, takes much longer for recovery, but you probably are slightly better off. I mean, there's no real study to show that you're going to be much better off or not.
Okay. Prem, would you do the same thing if it was a predominantly hepatic Wilson's? Would you slowly build it up, or you're happy to start 1 gram a day in a hepatic Wilson's?
If there are no KF rings, I feel confident to go on to the
full dose.
To the full dose very quickly, ramp it up from half a gram to a gram. But I have seen this even in younger children who've had liver transplants. And after liver transplant, they develop this mask-like faces and tremor. They look very Parkinsonian. it's almost as if as the new liver is functioning and the tissue pools of copper are being metabolized, presumably they go through different cellular compartments in the brain before they really exit, and it causes neuronal irritability. But
could you just take the mic close to you?
I found it very disconcerting after transplant to see these young kids developing really quite florid Parkinsonian tremor and facial appearance, but it was transient. And so the question is, in a patient like this, if you hold course, would this patient have slowly gotten better anyway? And what you are seeing this is, I guess, I mean, you know, I have no scientific evidence, but it is mobilization of copper from neuronal deposits that's causing this neuronal excitability. But we have an expert here who can...
Yeah.
That's the best explanation offered for this, that it is mobilization of copper. But I mean, you're right. I mean, most of the times if you dig your heels in and hold tight, they do start recovering. But sometimes they do get left with permanent impairment, especially speech, and sometimes dystonia, especially the hand dystonias. That doesn't recover for a long time. So that's the question, because you do land up with some permanent deficit then.
Yeah. So basically, this boy was just unable to get up from bed. He could not swallow. He stopped talking altogether. And we had to stop the D-penicillamine. What would you do? Reduce it, stop it totally, substitute it with zinc? What would be the best course in this situation? Ashish, any comments?
Well, I would stop it. More than stop it, I would restart it with very, very low doses and hope for the best.
Or would you just give zinc for a while and not take any chances?
He's deteriorated quite a bit. I'm not too sure whether zinc at that time would help, because zinc would give it for a very, very short time, not enough for it to really make him start going to a negative copper. So over a period of time, you have to restart dipenicillamine again.
Right.
And if you're talking about remobilization of copper, I think you need to make sure that the copper is coming out. So I would start, if I started on 2 and 2, I would really start with very, very low doses. This is an adult, but if it was a child, I would start 5 or 10 milligrams per kilogram to start with and slowly build it up and hope for the best.
Would you, Prem, consider strychnine as it is freely available to you? Would that be a drug of choice in this situation? And does strychnine do the same thing of neurological deterioration after starting?
It does the same thing. And I agree with Ashish and the strategy of building up slowly. I think the hardest thing I find in assessing the neurologic Wilson's disease is how much parenchymal injury has taken place. What is the extent of irreversible neuronal loss, neuronal injury? And this topic also becomes relevant if you got a patient who is severely neurologically disabled, and then you have to consider, because they are also decompensating, whether you want to do a liver transplant, because you don't want somebody with a healthy liver who is neurologically incapacitated. And I don't know if some of you remember the ASLD meeting many years ago when Tom Starzl presented the first case of Wilson's that he transplanted. This was a young man who was totally incapacitated, NG tube, dystonia, decerebrate posturing, horrible. And every hepatologist and neurologist told him, do not transplant this patient. And he transplanted the patient, and he asked him to walk across the podium. This was kind of Hollywood type of 6-foot guy, extremely healthy. And the key, I think that what this case, that example shows is our inability to assess how much recovery is possible.
Yeah. So basically, we managed to get some strychnine, but he did not get neurologically much better. We had to put in a PEG tube for feeding. He just couldn't speak. And his dystonia, rigidity got worse. He was getting contractures. And I want to ask Petrus, what additional drugs, this is a pediatric liver crowd, what are the additional drugs you have to sometimes use in these neurological patients to improve their symptoms, like tremors, rigidity, etc.?
I mean, we all would use, some amount of anticholinergics like Pacetane if there's a lot of dystonia, or if there's Parkinsonism, we've tried levodopa, but most of the times it doesn't really do much. I mean, I think the most rewarding ones which I have used is when there is a lot of contractures is to use botulinum toxin, because that really does much better on the symptomatic front than anything else. But I mean, because there's nothing else we can do, we do try baclofen, we try trihexyphenidyl, we try levodopa, carbidopa, but most of the times